I'm shorter than you. I want to welcome everybody tonight. This is a very special night. We've waited for this moment for quite a long time. Up higher? Okay, how's that? Okay, very good. Anyways, it's been a long time since we've all been together and we have missed it. And we're hoping that we'll be able to continue this for the entire next year if, Delta cooperates with us and everybody else does too. But I want to welcome everybody here. This is so exciting to see so many familiar faces and so many very great friends and colleagues. We will continue to learn in this next year as we've got lots of absolutely wonderful programs. But let's go ahead and get started. Admin notes, there are 2 exits. There's some out the door out here to the left, and then downstairs, the stairs, and out the back way. Oh, and out this way. Restrooms, if you haven't found them before, where you registered, they're just a little ways around the corner over that way. Are there any press in the room? Good. All right. Then let's see. I had one more note to go along. Oh, the doors lock at 6:30. So if by chance you have to go out for anything, make sure that you've got a friend on the other side of that door to let you in. Otherwise, that's it. So to start out the event, as you can tell, this is an incredible facility. It's not the Marriott where you had to pay for, well, we paid money for parking, but the nice thing is that we have such flexibility here, and LMI has been absolutely wonderful to support us in this. So to start out the night, I want to invite Doug up here, who is the CEO, Doug Wagner. Come on up.
Thank you, Ann, and would like to just take a minute to welcome everybody here to LMI headquarters. LMI is celebrating our 60th anniversary this year. 60 years ago, we were founded by John F. Kennedy and Secretary of Defense McNamara to solve some of the most pressing problems as a think tank back in 1961 rather, sorry. And today we continue to be a nonprofit, and it's one of the reasons why we have this great facility. Not just this room, but also a series of conference rooms back here, part of our conference facility, where we host government. Pre-COVID, I think just about every day there was meetings in this room, and you can have meetings up to the secret level in this room. It was very, very popular, and it's great to see folks starting coming back, like you all. We hosted the USO had their quarterly board meeting here Tuesday. And again, Tyson's is a very central location. Again, free parking. It's all about the parking. Free parking, and of course, all the other amenities here in the Tyson's area. So again, we're really, really proud to have HIMSS here. We've been a supporter of HIMSS for 20 years. We have been serving federal health care for 25 years. So it's a business that's very, very important to us. In fact, we recently made an acquisition of Sentiva. And Sentiva was primarily focused on the public health space and FDA and NIH primarily, and was one of the reasons we made that acquisition is our dedication to the health marketplace. And if you don't know Janet Webb is our Director of Civil Health and is a board member of HIMSS NCA. So again, I just want to thank you for coming, and this facility is available to you, Ann, whenever you all need it. Just get with Janet, and I'm sure we'll be able to accommodate you. So anyway, have a great meeting. Enjoy your evening.
What an incredible opportunity for us. All right, let's go to the next slide. Since we all missed out last year, a lot of these board members were board members last year, but you didn't get a chance to meet them. So I want to introduce each and every one of them. The first one to start out is our past president, Daryl Roberts, and I'm going to let him speak a bit.
Sure. As I do that. So I just want to say thank you very, very much to the members of HIMSS NCA who made it possible for us to continue to be a vibrant part of the HIMSS community and the health IT community through the lockdowns last year. I have the privilege and maybe very strange privilege of being the only president of HIMSS NCA that never had an in-person event. And this is really my first chance to reach out to you folks and just say thank you so much for helping keep us moving through this and for attending the lunchtime webinars that we had, and just thanks for everything that you did in the last year, and thanks for everything you're going to do in the years that come. Thank you.
All right. Our president-elect is Joan Bishop, but Joan is with the students. Tonight, we have an incredible crowd. We probably have over 70 students here from George Mason, as well as George Washington University, and probably a few other ones. So please, during the networking section, get out there, talk to these kids. Some of them are in their master's programs, some of them are in their bachelor's programs, and they're really trying to find out where their niche is. And you guys are the key to that. So there are a lot of extremely bright individuals, and so you could start recruiting now. So I encourage you to do that. Our secretary is Ann Kenny. Unfortunately, Ann was not able to join us tonight. In the back, I saw Darren Washington. Did he slip? There he is. Stand up, Darren. Give everybody a wave. All right. And he's been our treasurer, keeping our books straight for numerous years. We additionally have Nick. Nick is one of our past presidents, and he's taking care of charity. Nick, go ahead and stand up. Thank you very much. And we'll move on to the next slide. Mandy Packman, who is our program committee chair. And we are always looking for volunteers, you know, to help all of our committees out. But the program committee is so critical because that's what brings our members here. So anybody who wants to help out with the program committee, think about what type of programs you want to see in the future, as well as what speakers you want. Now, keep in mind, we are the only federally focused program. So that's the National Capital Area, whereas the Virginia and Maryland, they are, you know, commercial as well. So we, being the federally focused chapter, be thinking about what is it that you want to hear. And if anybody wants to help volunteer, put programs together, sponsorship, membership, anything like that, please come and let us know. Membership is Amy, and I have not seen Amy. Is she here? Okay. Otherwise, I would have her stand up. So she also does volunteers. So please contact Amy if you're interested in that. As far as sponsorship, again, Janet Webb, who also coordinates this wonderful event as well. We have some incredible sponsors this year and ones who have also committed to us. So please go back to your companies and encourage them to support HIMSS in every way. We've got lots of opportunities between charity, between just all kinds of things that they can help support us with their dollars. The advocacy and community is Dan Blum, and you will get the Blum report from him. Carol is our communication chair, and Carol looks over everything to make sure that it's in tip-top shape before we put it on the web or send anything out. And unfortunately, Carol was not able to join us tonight either. Our outreach coordinator is Barry Dickman, again, a past president, like Carol, like so many others. And Barry was not able to join us, but take note of all their pictures. And then the membership and scholarship. In the back, we have Maria, and she is taking care of the students and trying to mentor them and connect them, you know, with industry at large. So just a few other announcements already put on your calendar. Think about this program monthly. All right. It's the same time, same day, every single month. HIMSS 22 is just around the corner, 14 March. Okay. So be thinking about that. Block your calendars. It was for all of us who were able to be there this past year. It was wonderful. It really was. It was small, a little bit smaller, which kind of made it nice. But next year in March, I'm sure it's going to be great. And not as hot. Yes, it'll be in Florida. But HIMSS has also announced a new platform for that's called Accelerate, and this is a platform where you're going to digitally communicate with other chapters, with experts, with peers, and so please go online to the HIMSS website and sign up for Accelerate, and therefore you will get the latest and the greatest. And we encourage you all, because this is where a lot of the information is going to put out across the board. So with that, we are going to call up what you all have been dying to hear for the entire year, the Bloom Report.
Well, for those of you who've been here before, no, I have no qualms talking, and I can fill any time there is. Tonight, we have an important program and lots of things to hear about. So I just want to highlight a few things. What the pandemic has really done is change how we think about healthcare delivery in America specifically. HIMSS itself is now referring to itself as a global healthcare entity, a global focus, because we're learning from other activities in other countries as well as locally. But the pandemic has also pushed us ahead very quickly to think about what are the enabling technologies that will enable us to provide healthcare in the future in a more cost-effective manner that's more responsive to the community and drives what we call health equity. And if you were at a meeting, say 2 years ago, October, I spent about a half hour talking about social determinants of health, which is one of the major areas of understanding how our healthcare delivery system needs to understand and document the circumstances in which people receive their care and where they and how they live. So HIMSS has a much broader reach now, and they're rethinking their direction, their priorities. And I'll be sending out a paper, it's a couple pages, to help ground you in the fundamental aspects of how HIMSS is focusing. But as you can see from this very quickly, our mission is reform the global healthcare system. Our priorities are interoperability, connected health, and cybersecurity and data privacy. Next slide. I'm not going to read all of these. You can just read them quickly yourself. These are some of the key areas we're going to be focusing this year nationally at HIMSS. And if you'd gone to the HIMSS conference a month ago, you would have heard some discussions about this. The bottom line, though, is we are changing our focus and emphasizing certain things that will enable better healthcare delivery. And that includes things that Congress stopped in 2008 when we used to talk about a unique patient identifier. The pandemic has highlighted we need some way of making sure the people that are patients and using healthcare are correctly identified, because with more virtual care, telehealth care, et cetera, it's going to be far more important that we get some way of identifying how our patients receive and get their care documented. So the bottom line here is we're going to champion programs like maternal health care. We're going to focus on better on interoperability. And if you followed ONC the last couple of weeks, there's been a number of webinars and series on addressing interoperability and what are the standards are going to be. And the buzzword is health equity. How can we address healthcare needs using technology and information? And so that's the framework for our program this year and where we're trying to go. Next, please. I just want to highlight a few key things. The Global Health Equity Week is going to be the week of October 25th. The agenda is not out yet, but it's going to be nationally managed by HIMSS, and we'll be pushing information out to all of you to listen to webinars and to participate in different events of interest. And we're going to try to make sure you become aware of this. Again, it's going to be virtual again this year, not like in person. And remember, in years past, we would take members to the Hill to meet their elected officials and talk about hot topic issues. You can look for us on the website, and we'll be continuing to push things out. I'd like to ask Maria to come up for a minute and talk about the mentorship program and the charity program. And I'd also, while she's walking up, Jason, stand up, please. Jason, you stand up, Jason. I'm holding Jason accountable for helping me in the advocacy program and advocacy and community outreach, which includes advocacy and community, which also includes the charity that Chris will manage. Thank you. Maria?
So we are currently taking applications for our mentorship program. Each year we do a mentorship program for, oh, sorry. Um, One of the advocacy things that we do is helping and support rising students, people doing career transitions, young professionals who are kind of looking to navigate within the health information management and health IT space. So we're currently taking applications now for our mentorship program, which will run from October to May. And so the call out is if you know students who are getting out into the field and it maybe needs a little guidance, please point them to our website for some information. And if you're looking to be a mentor, we're always looking for mentors who can share their information. You have a vast amount of experience, and we want to make sure that we are sharing that with up and coming students and young professionals. So we did an information session last night, a recording of which is going to be on our website. The application's on our website under the tab Get Involved. And then for the students who are in the other room, I did leave my contact information on the whiteboard if you want to reach out to me. And if you have any questions tonight, you can reach out to Joan Bishop, Dan Blum, and myself. So please come talk to us. Thanks.
All right, now the moment that we've all been waiting for. Our last face-to-face program was facilitated by Colonel John Scott. Well, tonight we have our facilitator, Dr. John Scott, because he is now retired. So John and the rest of the panel, Lance Scott, and we've got several online, come on up to the podium. It's all yours.
Talking to myself. Is everybody unmuted now? Okay, now we're... No, thank you very much, Ann and Mandy, for helping to set this up. I'm really excited to be part of this panel.
Everybody here?
Can you?
Raise your hands if you've been here. Not many.
How about if I hold this a little closer to my mouth? That's better. Okay. But I'll start over. Thanks, Ann, for the introduction, Mandy, for helping to put this together. I'm really excited to be part of this panel tonight. And I wanted to take just a couple minutes to talk about, what is the problem we're trying to solve? What do we mean by this topic tonight? But I'm going to try to do that quickly, so I'm going to speak fast. Because I know we want to get to our panelists and hear what they have to say and then get to your questions. We're using the phrase population health rather loosely. Apologies to those who are in that discipline. But we mean pretty much anything a healthcare system has to do that requires the review and analysis of data from groups of patients as opposed to just one patient at a time. From the simple things like just having a list of who hasn't had a vaccine yet to more complex questions like, is our system appropriately prioritizing people with pre-existing conditions? To do that, you have to have more than just access to data. That data has to be combined in ways that preserve its meaning and make it available to analytic processes. And the healthcare providers that are as big and complicated as DoD and VA have additional difficulty with that because they've been evolving their medical record systems for decades, and they can't just turn on a dime. So they have a lot of data to try to combine and preserve meaning of to do that. Moreover, DoD and VA are not just providers of care, they are also purchasers of care, and so they have information from other healthcare systems that has to be combined for complete records, all of that adding to the interoperability challenge. While there's been a lot of progress made nationally in the systems that allow view and query of a single person's record at a time, including by the patient, additional work is needed to meet population challenges like COVID, where we need sometimes to get whole sets of data moved between one healthcare system and another. And we're very fortunate tonight to have panelists whose job that is, who are making that work for the DoD and the VA. We have from DoD, VA, and the Federal EHR Management Office that Lance is with. And full disclosure, while I have no financial commitments to disclose, I am a cheerleader of this work, have been for many years, and I think they're doing incredible work. And I want to list a few accomplishments that DoD and VA have, especially for all the undergraduates who are here. If all you see is congressional hearings, you wouldn't know that, what the departments have actually achieved. Both departments are members of the eHealth Exchange and Commonwealth, two of the largest national health information exchanges, and they have what's called an opt-out paradigm, meaning that less than 0.1% of the patients that we take care of have opted out of the HIE. Because of that, we're sharing millions of health record summaries between DoD and VA and our partners, and Lance can go into detail about that. Both departments also have a complete open notes policy. That means through patient portals that every one of our beneficiaries can access, they can get access to the entirety of their electronic longitudinal record. And since about 2015, that entire longitudinal record is made accessible through a common viewer platform that the departments both keep running, and Lance's office keeps that thing working. Also, and this is my last point before I turn it over to you guys, since about 2014, large volumes of computable data are shared between the departments for separated service members and other populations that we share. So we're actually doing all of that. You hear a lot about the parts of that aren't working perfectly, but that's the foundation that these guys have built and that they're going to continue to improve over the years to come. So I'd like to, at this point, ask the panelists to go ahead and introduce themselves. We'll start with you, Lance.
Sure, John. Thank you. My name is Lance Scott. I'm the Director of the Solutions Integration Directorate inside the Federal Electronic Health Record Office, Mr. Tinson. I've been in the interop space for a very long time. I remember when I first came on doing this job, the first person I went to was John when he was in uniform, went over to Walter Reed, and he sat down and explained to me what my system was and why it was important. And since then, as you'll get from this conversation, it's just grown exponentially. That's it.
Joe, why don't you go ahead?
Hey, thanks, John. So Joe Ari, I'm the Director of the Data and Analytics product line here at VA. I work very closely with John, so I'm hoping he won't hold that against me here tonight. What we're tasked with doing is taking a hard look at all the data investments across VA, be it for servicing our VHA, our VBA, or NCA partners, and trying to develop a cohesive strategy so that we can manage investments more efficiently and enable those shared services across administrations and get the right curated data products in the decision makers' hands for each of those areas. I've been at this for about 6 months, so I'll let you know in 3 years when we get some progress on it. But I'm pretty excited about some of the things that we've accomplished, especially around this topic. And John is one of my business partners who is, I almost feel like he's an OIT because I see him so much in meetings. I hope he's pleased as well. And to the contractor community that knows me, I apologize for not wearing a band t-shirt tonight. I thought I'd dress up for the affair.
Yeah, I'm not a data scientist, but I talk to a lot of them. Chris, go ahead.
Hi, my name is Chris Nichols. I'm the program manager of what's called Enterprise Intelligence and Data Solutions Program Office under PEO DHMS. Really, we're the secondary data PMO for all the military healthcare. Really kind of wearing two hats, running that data PMO, but then really working with Lance and many others driving data integration across the whole organization with our partners in the VA, but other federal and civilian entities, and figuring out how do we tie this all together with the new EHR, but also looking at the new EHR as one of many capabilities that we need to bring things forward with. As someone said earlier, we continue to talk about the fact that more and more healthcare is happening outside the walls of the hospital, and that's a transition point that we all acknowledge, but we're slowly moving in that direction. And so that's a big driver of how we have to look at things. Yeah, we'll go from there.
Great, thanks, Chris. And I'm going to take the first question to you. I know you could answer this question for a half hour. That would be actually very interesting. But if you could, you've been at this a long time. Tell us the journey that you've been on with the DoD's integrated data platform, and what have been your challenges in aggregating data to support clinical decision support?
Sure. as John was saying about being a data scientist, I'm not a data scientist. I'm actually a clinician. I'm a ER critical care flight trauma nurse by background in the Army, many years, and grew up in this health IT space, the informatics space, with many people that are, Ann and Dan Blum and John, and I saw Jason Windsor there and many other people in this space. And so, about 3.5 years ago, I was tasked to stand up take over this PMO and stand it up and really look at how do we integrate all these things together. We've integrated about 14 applications and about 22 warehouses together in the last 3.5 years. About 18 months ago, due to various reasons, we were on a 24-month-ish timeline to move to AWS as a cloud vendor and really re-platform everything. Instead, we did it in about 93 days, 93 daos exactly, actually, from plan to execution, partnering with 20 vendors, 14 cloud native solutions, 4 ATOs during that 93-day period. And we're slowly now learning and crawling on how we mature from there, right? Within the MIP, we've got the MHS information platform. We've actually got 119 interfaces as of today, is what my chief engineer told me. And when I say interfaces, I don't mean pretty things here, right? I mean some snail mail, I mean some SFTP, I mean a lot of different ways of us getting the data. And a lot of it is duplicative. And so part of it is us working through killing the duplication, bringing things in, re-platforming them, stopping that duplication, identifying data provenance, working through the 4 V's of volume, veracity, velocity, and variety of that data, and then maintaining that in a secure manner to then drive really what matters, right? Because all that's great. All that doesn't matter if it doesn't really affect healthcare, the way we manage healthcare, and the way we fund healthcare. And I think that's why this whole conversation is, between Joe, myself, Chris, John, and Lance are DoD-VA, but this is really a federal conversation. And that's kind of what we've talked about with the MIP, is that kind of call it our federal health data hub. And we're challenging everyone else in the health space, in the federal space, to say we're wrong and come and partner with us, right? And that's what's happening with Joe and the VA. That's what's happening with NIH and partnerships, especially in the research space, and how we then bring all this data together, prioritize the work that we're doing, and drive better outcomes in the work that we're trying to make happen.
I think we'll save some time to talk about just what some of the mechanics are of at least bringing the DoD and VA data together a little later. Joe, I wanted to give you a chance. I know you've been in the current job 6 months, but you're working with a whole lot of the same problems as Chris. Want to tell us the VA flavor of that?
Yeah, absolutely. I mean, interoperability across multiple systems, multiple partners, right, is daunting enough. But if you look at the history of VA and the autonomy really that was afforded at the VISN level, you're dealing with almost 130 healthcare systems if you think about it from a Vista perspective. And for those of you who have heard this before, I apologize for retreading that same ground, but there's a joke and an observation at VA, which is more true than you might want to believe. If you've seen one Vista, you've seen one Vista. John started laughing before I even got out of my mouth. But the reality there is that pulling that data together at the regional level originally, and now in a centralized location under our business intelligence service line and this corporate data warehouse, that's been a decade's worth of work. Right. And to do that, we've had some very sharp people that are technologists as well as experts on the business practices at VA. We have clinicians involved in that. We have clinicians who are technologists. VA, we've got a lot of people who span that spectrum of wearing multiple hats, depending on what day of the week it is. So when we look at that challenge, VA's interoperability opportunities really are the overused analogy, but you're peeling that onion. And that is, we've tackled some of the internal problems of Vista over the years. We've integrated that into a robust research capability, right? Where we really are tackling those what if questions and testing hypotheses across a large population of our integrated care. We've had kind of the traditional DoD interoperability. We've heard about JLV earlier, and we've got HDR out there and a number of solutions, right, that touch upon creating that shared data view, whether it's active prescriptions, allergies, labs, et cetera, of shared population patients, which is another tremendous opportunity that I don't think a lot of people really appreciate when we talk about our interoperability concerns. And then there's the one that I'm sure everybody in this room has seen at least 3 congressional hearings on, and that is our modernization of our EHR approach, which, despite some of the commentary on it, it's a daunting challenge, but it's also a great opportunity for VA because we're uplifting a lot of systems off Vista. It's about more than just EHR, right? If you're talking about logistics and supply chain and all of the things that are required to deliver quality care, all of those are really part of that. And again, standardizing that and pulling that out of the regional level and pulling that into a national view and giving our decision makers in DC and our regional leaders out in the VISNs, the people who are really out there and accountable for care to our veterans, the information they need to make smart decisions. And no more did we see that than with the challenges we faced with COVID. If you look at some of the work that we've done with the national surveillance tracking and access to care, public availability, I mean, that is the shining star of VA interoperability within itself. Taking that information that was previously buried down in the EHR and taking that out to something that an end user can consume on a public website. So I think as long as we continue with those themes, right, and we commit to that level of transparency and visibility, we've got nothing but success on the horizon. And as both Chris and John have alluded to, I think we're going to talk a little bit more about that in terms of how VA and DoD are going to do that in the future. And that's really something that I think we're all very excited about.
Thanks, Joe. Lance, want to switch to you a little bit, and we'll be tying these themes together as we go along. But again, just like I know Chris could talk about MIP for a half hour, and it would be interesting, you could talk about HIE for at least that long. But can you give us a sort of a summary of how the departments have come to the Joint HIE Gateway and what you see as the next big advances?
Yeah, absolutely. It wasn't that long ago when we were down to sharing about 6-7% of healthcare data between the DoD and the VA. Rapidly after that, it seems like just light speed. We brought on the Commonwealth Health Alliance network, 22,000 providers, eHealth Exchange partners. We've got 241. Doesn't sound like a big number. It's huge. We've started mapping in what I'm calling the Joint HIE heat map, the physical locations of every single facility within these HIEs, so that someday a provider will be able to put in a zip code and see instantaneously. They'll be able to draw right down on exactly where they are, what healthcare facilities are in the network, who exchanges data, and points of contact there.
You need an NPI Rosetta Stone.
Exactly. Back in April of 2020, right when COVID was hitting, that's when we stood up the first instance of the Joint HIE. It was monumental in that for the first time, the VA had their HIEs and the DoD had their HIEs, but we couldn't see each other's HIEs. We had kind of a stone wall in between us. Now that we had this Joint HIE for the first time, we were put together as a joint responder. When Inova or Kaiser requested records on a patient, they got records back from DoD and VA. It was absolutely huge. Now we're up to about 65% of the healthcare sector, and we plan to go up as close to 100 as we can by end of this calendar year, early next year, when we bring on the last few remaining HIEs. And I'll talk a little bit later about what's next.
Okay, we'll save that. Because how to get that data into the computable system is the next part of the challenge, right? But so let's go back, Chris and Joe. You guys can decide who speaks first, but what are the departments doing to improve the ability to share data for computational purposes?
Yeah, I'll start, Joe. It's transformation, and transformation is a change in culture and a change in the way things are done, and the way they're partnered and the way people partner, right? I have a 5 and a 7 and a 3-year-old. And if my 5-year-old trips my 7-year-old, she can't understand why they can't partner together. But the fact is they've got to work together as brother and sister, right? And I mean that in the same way at home, at work too. We got to figure out how to do this together. We all have different cultures. We all come from different cultures, and those are organizational cultures and personal cultures, but we've got to have that willingness to build it together and figure out how to knock down the walls and make those changes. I think one of the best things that came out of the last 18 months is the ability to get things accomplished in a timely manner during the COVID crisis. I mean, it didn't take 9 months to get 5 million people to check off on an agreement that from day one we knew was fine in the first place, right? And knocking down those types of barriers, just simplistic, and those aren't technology issues. Those are policy and process issues that if we don't force change in those manners, we're never going to get there. And so I think that between DoD and VA, I think what we've seen, especially not in those realms, is how we partner, how we can share together. We've been working for a long time. If you've heard of Da Vinci, it's a way we were trying to share for many years. We've built that, taken that into a joint VPN in order to share data in the near term for research purposes more and more. And now we're talking between PNR and the Defense Health Agency and us and the VA on both sides, VHA and VBA, benefits and health, really around this data mesh. And how do we start to really share data and information? And that's why I think this is more of a federal conversation and not just DoD and VA, right? Because if you think about that, then you can tie in other data sources. But then it's a trust issue too. And it's making sure that it's not technology driving all of this alone, but with the right partnerships. Because in the research space, it doesn't matter how quickly I can share data back and forth. It still has to go through that IRB process, that research protocol process for human factor sharing, right? And so that's one of many cases where we have to have the right partnerships to help really drive those things, not just with technology, but with also in the process and policy side. I don't know if I really answered your question, John, but I think there's many ways that we are doing it. And I'm seeing more and more because of COVID that we are driving things in a faster manner than we have been in the past. Joe?
Well, thanks, Chris. Yeah, echoing a couple of those themes that kind of drove your answer, which is, vendor selection does not equal interoperability, right? That's something I've been fighting with since, when I used to interconnect 911 systems and computer-aided dispatch in the years after 9/11 when we wanted to share data. And we saw how difficult that was even on the same vendor, right, across jurisdictions, because everybody views the world through their own lens, which to your point is the most important challenge to tackle. Software isn't going to make people talk to each other. It's not going to make people find creative solutions. What we are looking at in terms of the interesting technology changes on the horizon here, you have JVPN being a facilitator of connectivity, but the real change is, and what I really get excited about is when we talk about data mesh, we're not talking about moving around data. We're not talking about replication. We're talking about real-time access to curated solutions that we can use in real time for operational needs, for research needs. And we're going to empower not only just the transactional systems that our shared community of patients interact with and beneficiaries, but we're going to be looking at empowering data scientists to get insights that would never have been possible without real-time access to this information. We're really taking that burden of dependency off one another's organizations, because we build a curated data product, we federate access and just discuss what's the metadata behind it, what's the purpose of use for this, what do we know it's authoritative for, and we allow smart people to make creative decisions versus us dictating how systems are going to talk to each other. Yeah, you got to do some of that at a basic level to ensure that you're protecting information, you're being respectful and great stewards, right, of our shared population's personal data. But at the end of the day, insights don't happen because the ATO says they can, right? Insights happen because you've been smart about how you've architected those solutions and put security protocols in place to allow people that are way smarter than me, because I'm not a data scientist either. And you know, we were doing a local play, and I didn't get cast there either, so I don't even have that. I don't even play one on the stage. So we need to get those people enabled with real-time access. If you look at what DAPL, you know, my organization has taken over not only our you know, our data warehousing, our analytic insights, and some of those traditional things, but we've got most of the DoD data sharing. We have systems like Vader, right, that replicate military service history. Why is that important to VA? Well, we're not just a healthcare provider, we're also a very large benefits administration. And by the way, those determinations on benefits may dictate what you're really eligible for from a healthcare perspective. So it's very foundational data like that, that as we move beyond this, here's my data, let me just send all of it to you and you figure out what it means, to this is my data and this is how you access it, and here's the contract for access, integrate this where you need it. We're going to get hands-on data in the right places to make informed decisions. And I think that's going to be a tremendous game changer for how we accelerate, creativity. And if anything good has come, and I'm sure you've heard this before, if anything good has come from COVID, it's that people want to get things done. And that's really, I think, all of our rallying cry now.
Yeah, thanks, Joe. And echoing that and Chris's point about decision-making being accelerated, I would be remiss if I didn't mention that a big improvement in DoD VA activity in this space comes from the fact that there is a chief data officer in the VA now, has been for a couple of years, and he has a partner at the Undersecretary of Defense Personnel and Readiness in Mike Sorrento. The two of them were tasked by the undersecretaries to improve DoD VA data sharing. So we had a summit in February, and some of the more rapid movement on this has come out of that leadership. Just I want to make sure I mention that. Lance, I want to give you a chance to talk a little bit about how some of the new capabilities with the new EHR system are going to help us get more of the partner data into the computable data space. You go on that.
Absolutely. So I'll set the stage a little bit by a couple years ago, a few years ago, we started exchanging data, and we still do it this way today. We bring in CCDA documents, continuum of care documents. We parse that data out into what we should have gotten in the first place, computable data. That's what we want to get to. So I remember sitting in a meeting many years ago thinking, this is not scalable. We can't continue to get thousands and thousands, hundreds of thousands of CCDs and parse them into computable data. Well, the good news is that things are starting to change. We're currently exchanging, I think it's 11 domains via FHIR from Cerner Millennium over to JLV currently. That's going to increase to 22, 23 over the next year. We are also in negotiations with eHealth Exchange to make their exchange FHIR-based computable data. We want to be able to take that data and put it exactly where it needs to be, either in the JLV widgets or inside the Millennium record. Our current team does a great job of parsing that data out, but they can't continue to do it as this grows. As we go from 0% all the way up to 100%. That's one innovation is we need to streamline the way we get the data, and FHIR is one of those ways. The next thing is clinicians are faced with information overload. They've just got too much to do every single day. They barely have enough time to get through their appointments with their patients, let alone go to something called the outside records tab and reconcile external partner data that comes in. So the more data that I can take in from external partners and auto ingest that into the record that the clinician is already looking at, the better off they'll be. The good news is that VA is leading the way on this with something called seamless exchange. They're in testing for it right now. The DoD is a little bit farther behind, but we're definitely getting on the bandwagon. What this will do is this will dramatically increase our data provenance, like Chris was talking earlier. We'll be able to basically trace back the lineage of all data, no matter where it came from. And most importantly, to me anyways, is I will be able to with the functional's permission, take that data and auto-ingest as much of it as I possibly can into the record. And do we want to talk about healthy intent?
Yes.
Now,
Yeah, we probably ought to. It needs to be
So
part of our ecosystem, right?
healthy intent is actually my
Is part of our ecosystem.
healthy intent PM, extremely bright young man is here in the room, and he's making incredible strides in this area. The good news I want to announce is that Healthy Registries DoD is about to go live with in probably, 2 weeks, 3 weeks, something like that. We are going to immediately have access to 13 registries with another 9 in the hopper over the next few months, and that's going to just increase from there. That is something that the DoD functionals have looked at for a very long time. They've wanted it for a very long time. And Chris will probably talk about how we're going to eat into the registries that he has basically put up for the DHA for years, and we're going to solidify it and get it into the Healthy Registries platform. But healthy intent in a nutshell is the place where the largest longitudinal record will exist on any DoD or VA patient to date. It will be all the DoD legacy records, all the VA legacy records. Now, the DoD legacy data may not be in healthy intent, but wherever we decide to go there, Chris will make sure that there is a link to it so that at any given time, we will have probably the most complete set of patient data in one place that DoD or VA has ever seen. So, and I don't want to eat up all this time.
Yeah, and I can't resist saying something about, what we meant by this. So, many of the missions that the platforms Joe and Chris have been working to build over the years obviously should transition to the component of our EHR that's designed to work on population health. The departments are committed to optimizing our use of that product. That's not everything that we need to do in our analytics, though. And deciding just which is a mission that we transition to healthy intent and how quickly to do that is one of the challenges the departments have. Did I put that correctly, Joe? Put you on the spot?
Well, yeah, I don't want to be making a policy decision on the fly, John, but yeah, that's a sense, that's the conclusion a logical, intelligent human would make looking at that challenge, right?
Consider myself one.
Yeah.
So no, this is Chris. I mean, that's why I did that, right? And Lance and I joke about it. I've got a lot of historical things in the MIP that I've inherited over the years, and part of the goal is move them to the right place, put them in the right place that the users of our systems have access, so they're not going to multiple different places, right? And then leverage this big data platform as a big data platform for all that we can in the future, with the potential to tie it in, fire APIs, as Lance is talking about, et cetera, build decision support tools, still be able to present them to our users. And inherently, a functional should not care on the back end where that sits, right? That's our goal, and really is.
Thanks. We're doing work here right now. I'm excited about where we can go with all this, and having the three of you be able to talk about it. It's going to be great. I want to ask one more question of you all, and then we'll open it up to audience questions. And so try to answer this quickly. I know you could each talk about it for a while, but what do you think is going to be the biggest advance in the next 5 years? Chris, we'll start with you.
Everyone likes to talk AI, ML. I like to call it augmented intelligence, not artificial. And I think part of the biggest thing in the next 5 years is right-sizing the assumptions of the amazingness of AI and ML, and really start talking about how we can really leverage it the right way to drive better outcomes, drive better decision-making. And that's the technology side. I think the other one that's more important to me is the quality of the data. And so that's from a point of entry of the data all the way to the utilization of the data, and that really then becomes around self-service data management is what we're calling that. And then really looking at things that we are bringing forward in 22 and out around machine learning as a service. And I think the biggest key that I'm focused on is finding the innovation out in the organization and our partners and stealing it, right? Taking it, re-leveraging it, us building it and scaling the great ideas that people out in the field have had and bringing them forward as enterprise opportunities.
Lance?
So two things, how we transport data, how we get computable data, that's the technical side of it. I see that growing exponentially over the next year. And I'm going to pile on to something Chris said, data quality. That is absolutely huge. The biggest thing that has kept me up at night over the last few years is having to deal with, I mean, we deal with over 340 disparate data sources and thousands of providers. Every single time there's a problem that has to do with data quality, hands down. And I think I'm seeing that start to change. I think there's a sea change in the data quality improvements today.
Yeah, there's certainly a recognition where I work about the need for a robust stewardship program that'll be part of that. Joe, let you have the last.
Yeah, I'm not going to say anything that's too surprising. I think with a number of the programs that we have right now at VA, a lot of that is trending towards taking. I don't want to brand it legacy, but it's certainly got some gray hair. Some of the solutions that we have and moving them into environments, whether that be the cloud or adoption of SaaS, where my IT staff can focus on being good partners, right, for our business people and helping them achieve insights that wouldn't be possible if they were primarily concerned with watching lights blink and keeping infrastructure running. So turning our technologists into real partners to drive data insights is going to be, I think, the order of the day going forward for VA. And what I'm most excited about, all the technology investments, all the great things we're getting from the cloud, all the services we consume are really about getting the most out of the folks that we've had around that have 20 to 30 years of experience in VA and corporate knowledge that are instrumental to unlocking the real potential of what these systems can provide. And I see that on the horizon, and I'm pretty happy to be a part of that.
That's great. So I wanted to then open up for audience questions. I don't know exactly how we're going to manage that. Is there a microphone or? Oh, great. So raise your hand and they'll bring you a microphone.
So keeping on the subject of data quality and touching on something that Chris said, how and this is kind of a nebulous question, how do we approach that? How do we address that issue of data quality, of where the data leaves my hand as a nurse and gets entered into the computer and then goes wherever it goes? So how do we approach that? How do we address that?
Joe or
Sorry, Joe.
Sure. So I think one of the biggest issues that we face, right, and it's not just on health data, it's on data in general at VA, is that we get very disconnected from the people who are at times the subject matter experts in terms of can tell us what we're doing wrong and how we capture it in the first place. I think it's often overlooked in data quality issues is the human machine interface here, how we get a hold of this. Now, a little bit different when you start talking about medical devices and other things, IoT, right, where we're pulling things in. But the next aspect of that is we got to get out of the ETL business, right? I've got an army of ETL experts in the business intelligence service line. And what I really need is for us to get, to circle back to a theme we hit earlier on this data mesh concept. If we have contract-based access to data, right? We don't have developers making decisions at 11:30 at night about what a data element means. It's well described and the metadata is well understood. And the last piece of that is when we start looking truly at federating our data catalogs, and that's not just a VA issue, because we're going to do that with DoD as well. We're going to have a shared understanding, right, of what that source data is, and then what we do with it afterwards. And we have our tools that clearly describe the lineage of that data, right? Not just what the last hop was, but where did this thing start and how did we get to this answer? So that's a lot of answer. I admit I took a very narrow slice of how I answered that question, but it's the one that is most heartland for a lot of my systems right now that we're looking at. So I hope that provides some insights as to where we think we're going.
Daryl, go ahead.
Yeah, this is Daryl Roberts, General Dynamics. I am wondering, what are you going to be doing to audit the effectiveness of your interoperability, to evaluate whether it's going well, and how are you going to learn from the errors and mistakes that you make, and also from the things you do well? How is that going to be documented, and how are you going to evaluate that?
Okay, you want to take that?
Sure. We've put, I'll call it strenuous, onerous. We put a lot of requirements on our vendor for doing just that, reporting. We want to be able to see what we're doing. We want quality control of, we want to be able to, we want to do more than just be able to say, when someone calls for an audit on a specific person, we can tell them who saw what when. We want to be able to do more than that. We want to see what is the quality of our CCDs. And to that end, we've just entered into a business associates agreement with the VA to start making use of their Diameter Health tool that they use to measure quality of the CCDs. And oh yeah, that just happened like just the other day.
Is that Darren's?
Can I add a quick
I'm not sure.
follow-up to that?
Sure.
Just, I guess, having performance review and management by the contractor is a fantastic way of following that up. But I guess in terms of evaluation, it's really, looking at it from a third party, a disinterested third party, and how are you going to get that information pulled up so that you've got somebody who really isn't inside the ecosystem, but somebody who's outside looking in saying, this looks great, this isn't so great. How are you going to do that? And how is that going to affect how you build?
So
Yeah, we've talked about that in the past when I was at DHA, but we don't have a good, at the time I was there, didn't have a good program for that. But conversations, that these sorts of meetings facilitate with some of our larger providers like Kaiser is one of the ways to approach that. I don't know of a systematic way that we're querying our partners to see what they think of our outgoing.
no, actually, I think the first kind of foray into that area is what I just talked about with Diameter Health. And that's a whole nother conversation on its own. But yeah, that's the closest I think we've come to it.
Question?
Hey, this is Rohan Oswald from Amuta. So you guys talked a lot about data quality issues within the VA and DHA space, but also, specifically with federal healthcare, data privacy is also a big concern as well. So when you guys talk about AI ML use cases, obviously there's a concern building and training your models. You have to use sensitive information inherently to build your models. How do you guys think about doing advanced analytics with sensitive data, and how are you working to protect that data for the end users that you're serving?
Chris, you want to take that
So
first?
before I even talk the mesh, right? Because that's where we need to be going with it. Because going back to what Joe said, as you think about this mesh concept, the data doesn't leave the core environment that it was coming from, right? And so as we look at the MIP, part of my intent is, my goal is that I'm bringing people into the MIP to do that work, right? So that right there is a safeguard. That right there makes it inclusive. But in order to do that, I've got to provide the right tools, right? I've got to provide all the right capabilities. And that's what we're building out so far. I've got a whole team that is focused on nothing but data innovation. I got to tell you, that's the coolest part of my job, is the innovative work that we're doing in our platform and with our partners. And so part of that then drives that privacy and security issue, right? Because if we bring the right users to the right locations, I get it. Everyone thinks our data should go all these other great places. But first and foremost, I've got 9.4 million people, beneficiaries that I'm accountable for their data. And so if that means I need to bring the right partners into our platform to do those types of innovative works, that's the way we're approaching it right now.
Yeah, thanks, Chris. And that's a concept, we've, on the policy side, working with our IT leaders, we've been developing is we, DOD-VA, are in a unique opportunity. We can do advanced analytics and big data projects within our HIPAA-covered space. So we take our ethical obligations to our veterans' privacy very seriously, but it's our duty to provide better health care for them. So we can study the data and look at better health promotion capabilities, keeping all the data inside the platforms that Joe and Chris have created. Okay, 5 minutes, question there.
John, can you hear us from the other room?
Hi, thank you. I'm Kathy Westfielding. I'm adjunct faculty at George Mason University.
Sorry, we'll get back to you.
Oh.
Yeah, go ahead from.
Can I go ahead?
Yes.
On behalf of all the students that are in front of me who have come here to learn from you, how do they reach out and get educated and engaged with what you've been talking about, up to including understanding all the acronyms that probably some of you are writing down as fast as they could to understand the language. Right. Having worked at HIMSS for many years doing health policy student internship, I know I give them a notebook to just write down the language you're all speaking. So let them know how they can engage if they wish. Thank you.
I'll take that first. Kathy,
Yeah.
you prompted my point where I was going to end where my talking was. Like I said, we're doing a lot of innovative things and we have a lot of partnerships, and I'm always looking for amazing talent, and so are these guys. And so there are people in this room that have my email address. I can bring you into conversations. We can have those. We have opportunities. I've got a lot of smart folks that, that are looking at how do we partner with students. We actually have some professors on our staff. And so I'm more than open to those types of conversations, and we're always looking for great talent. So yeah, feel free to reach out.
Yes.
I'm not technical enough. Okay, got it. I'm not sure that I heard a discussion about the VA registries and how you will be leveraging the immense amount of data you have in VA registries for research and development in the future. Is that part of the solution and interoperability that you're building today, Joe?
Yeah, so I think one of the registries that you could talk about is burn pit and some of the other environmental exposures, right? That it is one of the ones that always comes to the forefront of my thinking when we talk about this, and not only just because it was in the most recent National Defense Authorization Act language on it, but I happen to be pretty close to some of the efforts that we have working with DoD right now to integrate some of that exposure record data in the program we call EILER. We are doing it for just that reason, right? I mean, primarily, hey, get the data back to our veterans, right? Our people who are here for care need to know what DoD knows about them, and they need to know what VA knows about them. And that's just another component, right, of that theme. But also we have a number of epidemiologists, right, within the VA space that want to take that data for exactly what you're describing, which is, can we build predictive models that allow us to do either early screening or the early detection protocols that would enable outreach to a potential, a potential patient, a veteran, based on what we know about them. So yes, very much so in the realm of getting that into the hands of our researchers. There's a very large, well, not large in the federal government sense, but large in impact effort underway right now to do just that. So yes, very, very much top of consciousness for VA.
I'm getting the signal that we got to wrap it up. So we're in our last minute or two, and we have one more question. Great. Then okay.
Hi, Peter Rubacki with Privacera. So I'm curious about how the system is structured, because I've read a little bit about it, and that you brought 60 different applications of data from 60 different applications into this one system. And they used the term in the article that it was a secondary system. And I'm curious, is that the term for a data warehouse, or is it also something that people can access? Because you also mentioned real time. And to me, a data warehouse is different than a real-time system. And I'm just curious, how much access do people have to this in terms of seeing data as it's developing?
Right. I'm going to, before I hand it over, the vocabulary is such a huge part of this. We talked about registries before, and people don't always mean the same thing. You're asking, what do we mean when we say secondary? In healthcare, we think of the EHR itself, and the direct, that's where the clinicians are interacting with the data as primary. And anywhere we take the EHR data and put it in a system to do study is secondary data use. That's how I see it.
Yeah.
Chris, Joe, correction?
No, absolutely. And when you talk secondary data, it's not the point of entry system, right? Like I talked about, I have 120 feeds of data. That's all coming from somewhere else. But the real value, the real juice of that data is when I take that EHR data and I merge it with administrative data around those patients, or looking at staffing models for that healthcare system because of the system that they put their local information in, as far as their hours that they work and where they work, et cetera. That's really the value, and it's bringing all that data into that secondary system in order to merge it and grow it and go from it from there. So yes, that's absolutely exactly what we're talking about. So I think that's the last question. I will say real quick before I get off, I hope that Washington football team, you guys do better than you did last week. So good luck tonight.
Be quiet there.
John,
Yeah.
John, it's the other room. Can we sneak one more question in quickly?
And can the other room ask one more question? I'm not in charge here. Yes, please go ahead.
Hi there. Thank you so much. My real curiosity is how fast you guys think that you're going to be able to get to what I would call like speed to genius, that would then get to a point where you not only have the information, where you can get it into the hands of the smart people who can make decisions, like the clinicians and the administrators, and then leverage it to make business efficiencies at the end. And
We're not hearing the rest of the question.
I'm sorry, and then to lever that speed to genius, the clinical data, and helping the patients, and then actually being so smart about being able to have predictive models, cure people faster, everything wonderful, and save money at the same time. So then you can plow it back into your systems, make them smarter, save more money, and everyone's great. Do you have actually ideas? I keep
Lifetimes.
I apologize. I need to hold it to my face. So what kind of predictions are you trying to make that when you get to that 100%, when you have the data in and you're fully linked up between DoD and VA, do you have a 1-year plan for that, a 5-year plan for that? Because Chris, you made a point of saying how quickly you were able to move ahead during COVID, that there's nothing like a world crisis to get people moving.
It's a continuum. We're doing some of what you talked about now in both departments. Doing it with the whole volume of our data just increases the power and the speed with which we'll be making new discovery. I'm very optimistic that we are already beginning to do some of what you talked about, and that with the work these folks are doing, we'll just be doing more and more of that. I think we have to.
Sorry, but that's enough time that we have tonight. Next slide, I think. I do want to definitely. How's that? Oh, yeah. All right. I do want to thank the sponsors because without them, we wouldn't be able to put on these great events and be able to offer everything that we do. Want to make sure that, again, anybody who's interested in volunteering, then please go to our website, and the more volunteers, the better we can make the whole event. I do want to thank our panel, Joe, Chris, Lance, and John. Definitely, you for facilitating. You guys have done an outstanding job, so let's give them a round of applause. So tag your HIMSS National Capital Area website and be looking for our fall events. And please, bring your friends. This has been an incredible group. We cannot thank you enough. We love the students, so please make sure that you're interacting with the students. Help them understand what all there is to offer out there in the health IT realm. And so with that, if you will just drop your name tags off in the box as the way out. But again, thank you all for coming. You guys really make a huge difference. Thanks.